So moving on, I'm going to talk about change management required to actually help improvements in quality practice. I think we've talked a lot last year. Who's actually been to the APNA sessions last year? Okay, so there's only a few. Okay. So we have talked about, frameworks that we can use to help with change management. And I really want to talk about how nurses can lead this change as well. Has anyone of you seen the APNA survey? So this is from 2017. It's only 1,700 nurses, but 80% of them said that they were satisfied in primary care. And what's the most satisfying part of the job was still caring for the patients and families and collaborating as part of a team. And I was really, felt great when I read that collaboration and that teamwork is really important, because that's actually what we want in general practice. They actually wanted to be involved in positive health outcomes, and they want to feel valued. So I think all of you in the room would actually understand that human engagement is so important, and that you can't do anything in change management without that human relationship. Our nurses being fully utilised, it was quite interesting doing the activity. So 29% said they weren't, and 390 nurses actually spoke to their managers and asked to do more, and a lot of them couldn't actually then extend their skills. And there was, reasons for this, financial and resourcing, which, is mentioned here today, but also lack of support from the broader healthcare team. I do have to say that many years ago we had a GP that didn't want our nurses doing a history, because I said, our nurses should be seeing new patients, they can just add so much. Kirsten was actually at one of our staff meetings then, and she goes, that's just disrespectful. I'm going, it's disrespectful. That GP no longer is part of our team. She didn't actually have the same cultural ideas that we did, because we really believe in our nurses. I think most of you have seen the quadruple aim. Is this new to anybody? So you've all seen it. So I've just tried to adapt it to what we're doing in our practice and how I think the quadruple aim is actually helping us. So improving the population of health is a really important role for nurses in practice. So you can focus on prevention. We have guidelines and support, so health pathways, and I know there's other things used in different parts of the country. Identifying care gaps is a really important thing that you can do, and quality improvement activities that really count. You can help drive the quality improvement. You can, think that you want to improve the diabetes of your patients, or postpartum checks for mums at 6 weeks. There's lots of things that nurses can do to help drive these changes. A lot of you are doing dedicated clinics, a lot of you are doing health coaching and smoking cessation. Reducing the cost in the practice is using effective roles like team, and I also believe that nurses shouldn't be doing things that are sort of mundane, like checking stock and things like that. So somebody else can be doing those roles, not a registered nurse after 3 years of training. Lean thinking, I think a lot of you have heard about. And improving the work life of staff is really, really important for us. And I think having nurses satisfied with what they're actually doing and going home happy and being part of that team really does help with that. It also helps with the doctors as well. As Kirsten says, she goes home knowing that somebody else in her team is actually working for that patient, not just her. The responsibility isn't just all to the GP. I think you can retain staff better if you actually make them all fulfilled in their roles. And they've got flexibility and innovation. I think there's a chance that the patient actually is more empowered and actually feels better about their health when they're working with practices that are doing the quadruple aim. So I've talked about, what culture is important, but it's actually essential, and the human relationships. It's all about the why. So when you go into practices, you actually have to ask them, why they're doing what they're doing. I don't think any GP went, into general practice thinking that they wanted to be burnt out and exhausted at the end of the day. I think they actually, and nurses went in, when they're at university and thinking about what they wanted to do, they actually want to go in to do a good job and to make a difference in people's lives. And I think when we're doing team-based care, we can do that. I think they've got to internalise the quadruple aim, what's really important and why are we doing this? and empowering people. I think it's really important to have a just culture, to get everybody to actually speak up in your practice and to actually have a safe environment. So I can be challenged as a manager, and I can also challenge my staff to actually upskill and to always do quality improvement. I need to ask my staff, what do they want to give up? What do they love doing? Because sometimes there's things you're doing in your life that you don't want to do and you don't need to do and you want to pass on to somebody else. And as Kirsten said, use a doctor when their opinion matters. It doesn't always matter. As I said, just an example of the dressings. A nurse is competent to do decisions like that. Have any of you looked at the resources for the Institute of Healthcare Improvement? Yeah, I actually use them quite a lot. They've got some great frameworks, they've got some great opinion pieces, but this is one on leadership. And it's really important to be consistent and person-centred when you're actually a leader in a practice. And I think, as PHNs, you're going into practices, and I think these are some, things that you can also role model. You have to be authentic with the people that you're working with. You have to remain focused on the vision. One of the things that I did years ago is actually redid our vision and our mission, and we undertook the values. I actually asked all our staff, what values are important to you as an individual, and what values do you think we've got as a practice? So I think, if they haven't actually looked at their, vision mission statement, if it's been 10, 20 years ago when they actually started the practice, maybe that's an activity you could do with them. Transparency, I want people to see what we're doing. We put up our results in the tea room. I try to communicate, frequently with my staff one-on-one and, as a practice and talk to them about what we're doing and where we're going. And encourage practice systems thinking. You actually need to have some science behind it as well. So change management, as I said, it's about the human. It's about activation as well. There's no point in me thinking that things need to be done without actually following them through. And we have to test change. So just start with the why, as I said before. So it's so important to actually believe in the vision and internalise it. So change management is a way of thinking, as you know. Have a lot of you done courses on change management? Yeah, so I'll skip through some of this because I don't want to preach to people that already know it. But, making strategies to support behaviour as well, and you actually have to make sure that there's policies and procedures that are actually going to support them. It's about co-creating health together and having a new vision together. Everyone in your PHN and practice should identify ways of doing things better and getting work done. For example, my reception staff wanted to do a new way of doing faxes, and so they spoke to me and going, yeah, come up with a system. I'm trying to teach them to do a PDSA. I have to be truthful that I have overcomplicated them in the past. They should be simple, they should be something pretty quick to do, and so that's what I'm trying to teach people as well. They also did things about changing the way we're transferring files. So we use dropship, and now we're actually teaching other practices to use it. A lot of people are going, well, we can't do that, we can't receive a file like that. Well, you can. It's a good way of doing it. So it's actually empowering not just the nurses, but the reception staff as well. And it's about getting the best, not the most, out of people. And so having those conversations, I did a leadership course a couple of years ago, and one of the most important things I learned is having a 12-minute conversation with my staff, so one-on-one. So I'd recently been away for 2 weeks, and then I came back last Wednesday, and I spent, the first day seriously having conversations. Everybody wanted to see me. Someone said, it's as though you've been gone for 6 weeks. No, it wasn't 6 weeks, it was only just 2 weeks. And I spent my day, even though I had a whole list of other things that I wanted to get done, talking to my staff. I think that they need to feel that they can walk in and talk to me at any time, and that's how they feel. And I have to listen. There's no point in them talking to me and telling me things if I'm not going to follow through. So what they tell me, I actually then have to think, how can we change? Is it a system issue that I need to deal with? Is it a personal issue? And what can we do as a practice to help them? I ask them what their strengths are and what they want to improve as well, because I do like to challenge them a little bit. And as I've said in the past, what do they want to give up? Sometimes you can't give up some things. The receptionist will say whingy patients, but that's just part of it. I think when you're going back to these practices at PHN, how many are you working with the dyads? So the clinical manager and the practice manager. Are you finding that they've got them in practices? So are you just talking, so just put your hand up, are you just talking to a manager when you go back to the practices? Are you talking to nurses? Who are you actually talking to? Just a bit of a shout out. A bit of both. Presentations as well. So do you actually find that the successful practices for change are ones that have got a clinical champion? It could be a GP, it could be a nurse, and a manager that are working together. Yeah, a lot of evidence shows that this is what you need for successful change. So it's okay to have a GP with a vision, but unless you've got someone working behind them that's actually going to put in the policies and procedures and the things that you need, it's hard just to have that vision. So if you've got a team that works well together, that has regular meetings and communicates those changes, that's what you need. You also need to look at barriers for change. I don't want to talk about government policies and financial issues, but that is one of the barriers we all know in the room. And what are the drivers? What can we help change? What's people's purpose and shared vision? I went to Oregon 2 years ago, and I know this slide was taken of a slide, but I actually think it's a really powerful one. So we've been working with PDSAs, but it's also about workflow design. It's about training and education. You can't expect people to do things unless you've given them supportive skills behind them. You need to train up staff. I mentioned one of my nurses has actually done diabetes education. So for her, she felt that she needed more. I didn't actually ask her to do that. I did empower her with more knowledge because we started doing diabetes clinics, which I'll show you a photo of soon, and she chose to do that. So I will make time available for my nurses to actually do training and education. I took one of them to Tasmania with me last year. She's actually just been to the IHI conference, so she said no, and the other one couldn't come. But I do really encourage them to go to conferences, to upskill, to do as many courses as possible, and I give them the time to do it. They've been working through the modules for the healthcare home. They do lots of other training as well. We need to have policies, as I said, to support these nurses. We can't just expect them to do a lot in general practice without giving them the support with policies. And I mean, that will also help with when you were saying before with insurance. You can't expect people to be working outside their scope, so give them a scope, give them a framework. And you need to look at data. That's a whole talk, but I think it's really important to look at data. And if you're actually doing change management, you can look at data at that too. As I said, it's allocating resources, looking care of the team and laying the foundation. Kirsten mentioned the building blocks, which is a framework. So they went to 23 high-performing practices in the States and said, what are they all doing well and what can we improve on? That's why the building blocks came about. She had a different slide, but we're talking about laying the foundation, building relationships and changing the delivery of care, and also looking at the barriers. So access, as she's mentioned, is a really big issue in the States, but it's actually not such an issue here. I know that there'll be practices that know that patients can go into a practice down the road if they don't get the time and the doctor that they want. So the healthcare home, at least we have an enrolment with our doctor, and we can actually then provide extended care to them. So we can do, emails, we can actually get the patients to see the nurse instead, so we're actually improving access that way. This is part of my integrated care team. So we've been involved with the integrated care trial with New South Wales Health for a couple of years now. We've got about 90 patients in that. This is Farah, one of my nurses, Tim in the middle, who's my pharmacist, and Nicola, who's the care coordinator. And the care coordination role is a really important role in our practice, and she actually outreaches to patients and talks to them about delivery in the community as well. This is the diabetes case conference. So this is Kylie, one of our nurses in the middle. And we started doing these diabetes case conferences a couple of years ago with an endocrinologist and a diabetes educator, as well as the patient. And then I realised how important to bring the carer in as well for these case conferences. So now we're actually hardly ever doing these because we've actually upskilled Kylie, we've upskilled our doctors so we can start insulin. I was actually, when Kirsten was talking about that case, I was thinking, why didn't they start insulin on that patient? But anyway, it's just a thought that I had. But our doctors can do that now. They can start and have confidence in starting insulin because we've upskilled. So I'm talking about upskilling not just the nurses in practices, the whole team. Another example of this is our COPD. I just had a feeling that we weren't doing it so well. I tried to get data, and as you know, when you're working with PenCat and say best practice, you can't pull all the data that you want. So we actually tried to upskill our COPD. So I had a respiratory physician who came out, who spoke about spirometry with our doctors and actually tested their skills and knowledge about that. Then I had 2 nurses from the breathlessness clinic at the hospital to come out to check the technique of our nurses. So it's about upskilling and empowering them. And so now I know that our nurses are doing a great job and they're doing spirometry and they know it as well. And, we're improving our outcomes for patients because of this knowledge. It's using people at the top of their ability, as we said, and I'm actually happy to listen for changes. So one of my nurses, who was only a second-year nurse, came to me and said, I'm really unhappy about the way that we're doing immunizations. And I said, well, tell me, what are you concerned about? She goes, well, we spend 30 minutes with the patient, we undress the little baby, sometimes they go back to sleep, then they're waiting in a sick waiting room for the doctor. And I said, well, what do you want to do to change it? And she said, well, can I design a new way of doing it? And I said, sure. And so her solution was to actually have 30 minutes with the nurse. The doctor has 15 minutes and pops into the nurse. So we've given all our doctors laptops now, and so then they actually go to where the patient is. And that works really well. Now, Kirsten's not here, but when I showed her this slide, she's going, that doesn't look like a very happy patient or nurse, but it's meant to be, just pretend it's a happy one. One of the things we're doing is pre-planning as well. So if our nurse isn't totally booked out, she'll spend time the day before a consult and do pre-planning. So when we're talking about some of those care gaps, so she may look if there's a mammogram due or if there's a health assessment due and actually do that planning and then call the patient, bring them in to come in to see her a little bit earlier than the doctor. And she actually feels more fulfilled. She feels as though she's doing a better job with these patients and happier, and that's her quote there. The huddles have actually been a bit of a huddle for us. So my problem is because I'm trying to let people do the hours they want. My nurses start at 8:30 because they do a drop-off. Some of the doctors start at 8, and I've got others starting at 9:30 because they've got different school drop-offs. So our huddle has been a little bit of an issue trying to get team members together. We're currently rebuilding our practice and we're doing a co-location room. And I went to a meeting with some of my doctors on Tuesday night, and one of our solutions was to do the huddle at lunchtime. So that's what we're going to try and do in our co-location room in the future. And I'm pretty excited to know that we're going to have that because, as I said, it's lots of changes. Sometimes you can do structural changes, sometimes you can't. As I said, we need to actually give a framework for our nurses. So this is one of the things we've done. So we've looked at evidence-based guidelines and we've actually given them some concrete structure around what they can do and what they can't do. So, when can they order a mammogram, when they can do a spirometry for a patient. So it's looking at the evidence and then giving them support with that as well. The standing orders, I think quite a few have seen standing orders, but we've done them for spirometry and FAB, and we'll be adding to those as well. I just wanted to quickly talk about healthcare home enrolments because I would say most of you would be going out to healthcare home practices. Is that right? Yeah. No, some. So please excuse me if you're not, but I'll just quickly talk about healthcare home. So we've got one of our nurses, Kylie, who loves doing healthcare home enrolments. We've got about 125 healthcare home patients at the moment. And it's actually really, it's a good example of empowering the nurse and actually getting her to work to the top of her licence, as the Americans say, or just doing work that's valued and important and actually working with the patient in collaboration. So they spend 45 minutes. The doctor is the one that actually comes into the nurse's consult, not the other way around. And so we're actually getting the nurse to lead this. They do a PROM, a patient-reported measure. How many people know about patient-reported measures? Yep, there's a few of you. So I actually think it's a really valuable tool. So we've been working with New South Wales Health, so I'm sorry for people that are from different states. But a patient-reported measure, we're looking at 10 global health questions. So we're asking the patients, in the last 7 days, how is your fatigue, your pain, and things like that. And it's really valuable to get this information before you go on to do the tool, the HARP tool for the enrolment. And you're finding out a lot about the patients. So Walls had a patient say, he had like an 8 on the pain. And then, when he asked what his goal was, it was, to play golf, and he couldn't do that because of his pain. He said, well, why didn't I know about your pain? He goes, oh, well, you can't do anything about it, doc. Well, he could, and he did. And it's only because we asked the question, and this was the patient that he thought he knew very well. So I think it's really important that sometimes you don't assume these things about patients, that you do ask them. So we do it for enrolment, and then we also do it at a 6-month check. We can't do it for everybody because it is a resource. We use it on a tablet. It takes time to do it. I've been at a talk talking about problems before. They're going, why don't you do it on everyone? I said, because we can't do it on 10,000 people at the moment because, our software, the way it is, we do it on a tablet. We've got to still upload that into the doctor's notes. So they go into investigations and they allocate them into correspondence. But that all takes time. So we do it on the population we think that's going to help the most, and that's our healthcare home and integrated care patients. The nurse also looks for care gaps in these patients. We also put them on a healthcare home Excel spreadsheet. So who does what for this patient? So every patient who's a healthcare home patient has got the name, the provider, what needs to be done next for them. So we're trying to look, we were talking about registries, we're trying to look at what we need to do for them and actually making sure we're fulfilling what they need done for their healthcare gaps. And then, of course, re-stratifying them. So I think when I've gone around to some practices and heard feedback at different meetings, people are saying, but what's in it for the patient? Why should they be part of a healthcare home trial? And this is what we say to our patients, about empowering them, about giving alternative service delivery. And they're part of the team, and it's not just the doctor. And we talked about access, they can come in to see the nurse. We actually can email the patient, we give them a dedicated healthcare home email. So we're giving them better access to patients, and they're actually not seeing different providers in their practice unless one's away. So we're trying to tie up a different GP with another GP if they're away, so that these patients get consistent care. It's about care coordination for them and having that shared care plan. And I know we talked a lot in detail about the shared care plan, but this is really important. What are the patient goals? What can we do for them? And making it patient-centric, and also looking at their activation scores for change. And we actually, who's done the HCHA with their teams? Have you all gone round to your practices and done them together? So the healthcare home ones? I know Wentwest have done them. Tassie's done them, yeah. So one thing that I got out of this, we did quite well in leadership, but there was one question number 4, that we didn't, and it was about the way we were communicating. So I actually, as I said, I'm happy to learn and improve. And so we had an immediate action for that. So part of that is now we've got this quality improvement task force. So now I'm not leading all the changes. We've got a GP, a registrar, a nurse, we've got an MPA in training and a receptionist on this task force. The first thing that they're looking about is the frail scale. And then Kylie just came back from the States and she goes, you have to put nutrition on for the elderly as well. So we're having lots of feedback from different people about how we can improve. And I thought having a registrar on it, which is somebody from different practices that's got different ideas, is a good way of doing this. So it's not just my ideas for change. The second thing they're looking at is postpartum depression screening for mums. I may just leave that to after. Has anyone got any questions about that or things that we're doing?
Can I just ask, you mentioned before that you use Dropshare for the practice.
Dropship, yep.
Where is it based cloud-wise? Is it based within Australia? Or?
I think it would be. Well, actually looked into that because, as you know, he's got that medico-legal background, and it took us a while to find somewhere that we could use that was safe and Australian-based. So, yeah, but I can get you more information about that later. Yeah. Okay. We've got an activity later, but we're going to move on to another talk first. If there's no more questions. Okay.